Dear audience, dear chair, welcome on my one-year progress report on my PhD thesis, which is investigating the effects of biologics on the comorbidities and microbiome in psoriasis. Psoriasis-related inflammation markedly increases the risk of cardiovascular events. The most effective treatments in this disease are biological therapies. However, their impact on cardiovascular risk remains a very controversial topic. According to our results, biologics did not increase the risk of cardiovascular events, which means they are safe to prescribe and patients eligible for earlier access need to be specified. However, their potential in cardiovascular risk reduction is a topic which still needs to be explored. My name is Mária Veronika Kolonics. I'm a medical doctor and a PhD student at the Department of Dermatology. And my mission is finding the best therapy for psoriasis, while my mission is a decreased disease burden in psoriatic patients. I have two specific projects. In my first project, I would like to investigate the effects of biologics on the cardiovascular risk of psoriatic patients, while in my second study, I would like to conduct an observational study about microbiome. The title of my first project is investigating the effects of biologics on the cardiovascular risk of psoriatic patients. Psoriasis is a chronic recurring autoinflammatory skin disease with a world prevalence of 2 to 3%. In psoriasis, there is a systemic inflammation which involves not only the skin and joints but also the cardiovascular system. In the pathogenesis of psoriasis, mainly two pathways are present. In the interleukin-23 Th17 axis, there are some dysregulations, and as well in TNF-alpha mediated pathways as well. These pathways are also present in the formation of atherosclerosis and cardiovascular diseases. In psoriatic patient population, the risk of major adverse cardiovascular events is higher, while the life expectancy is 5 years shorter. Psoriasis is itself recognized as an independent cardiovascular risk factor. Only 1 point elevation in psoriasis area severity index contributes to 4% elevation in cardiovascular risk. According to our prior research, we found that TNF inhibitors decrease the risk of cardiovascular events effectively. However, besides TNF inhibitors, there are some other novel biologics which are targeting the interleukin-23 Th17 axis, and the effects of these biologics on the incidence of cardiovascular events remains a very controversial topic. That's why our aim was to compare the effects of biological therapies on the risk of cardiovascular events on psoriasis. A clinical question, according to our former results, was which biological therapy reduces the cardiovascular risk in psoriatic patients most effectively. We would like to examine patients who have psoriasis, and we would like to compare the effects of biological therapies on the risk of cardiovascular events. Our hypothesis is that interleukin-23 Th17 axis inhibitors are superior to TNF inhibitors in cardiovascular risk reduction in psoriatic patients. The clinical implication would be choosing the most effective treatment for psoriatic patients at high cardiovascular risk. Here you can see my search key. First, we had almost 15,000 hits. We selected more than 3,000 eligible articles, and it turned out we could include 129 pieces of them into our meta-analysis. Let me jump to my results. My main 4 outcomes were MACE, like major adverse cardiovascular events, myocardial infarction, stroke, and cardiovascular mortality. And we analyzed these 4 outcomes in all the 4 big biological groups which are used in psoriasis. Let me show you all of my results. Well, what you can see from this slide, that these results seem very uniform, but let me explain it to you a bit closer, okay? So here we see the same results which were presented in the previous slide. In the column, you can see my 4 outcomes like MACE, myocardial infarction, stroke, and cardiovascular mortality. Each color means a different group of biological therapy, and you can see as outcome measure the proportions here. If you observe it a bit closer, you can see that the proportions in all the 4 outcomes, in all the 4 biological groups were completely 0. Our study had some strengths, like we included high number of randomized studies, and we analyzed all the biological groups which are used in psoriasis. However, the follow-up periods were very, very short, and we also included articles which had low event numbers. So what can we say according to our prior results? We can say and conclude that biologics do not increase the risk of cardiovascular events in psoriasis, which means physicians can safely prescribe these highly effective therapies without the fear of any cardiovascular adverse event. However, further studies are needed to explore the use of biologics in broader populations, and their potential in cardiovascular risk reduction is still a topic which needs to be explored. Here you can see the progress of my first project. Next week we are starting to write the manuscript. And let me jump to my second topic, which is investigating the effects of microbiome on the therapeutic success in scalp psoriasis. Psoriasis, as I mentioned, is a chronic autoinflammatory skin disease affecting 125 million people worldwide. 80% of these 125 million people experiences scalp involvement, which means a serious loss in quality of life, and scalp psoriasis is considered to be a difficult-to-treat psoriatic area. In microbiome research, there is a term which we call alpha diversity, and it expresses the variety of species within a single sample. Our research has found that in scalp psoriasis, both fungal and bacterial diversity correlate with disease severity, and we suspect that maybe not just disease severity, but also the therapeutic response might be influenced by the alpha diversity. That's why our aim is to analyze whether the alpha diversity of microbiome has a role in the therapy resistance in scalp psoriasis. Our clinical question would be, how does the alpha diversity of scalp microbiome associate with therapy-resistant scalp lesions in psoriasis? We would like to build 2 groups according to therapeutic response, and we would like to observe as outcome the alpha diversity, which is measured by the Shannon index. Our hypothesis is that higher alpha diversity of scalp microbiome decreases therapeutic response in scalp psoriasis. The research implication will be providing information for future studies investigating the treatment of scalp psoriasis. Here you can see a brief summary on my 2 projects. We wish to finish the first one until Christmas this year and the second until spring next year. Now I would like to close my presentation with the words of Friedrich Nietzsche. The belief in truth begins with the depth of all truths in which one has previously believed. And I would like to thank you for your kind attention.
As I'm also a dermatologist PhD student, I don't have the knowledge, but can you mention other specialties that use the same biologics as your studies?
Thank you for your question. Yes, many specialties use almost the same kind of biological therapies, like pediatricians as well, as far as I know, but it's more typical for rheumatologists, especially TNF-alpha inhibitors, and sometimes also ophthalmologists when treating uveitis, and also gastroenterologists use them.
I kind of have a question related to that one. So in the first project, you mentioned in the future research implications that the use of biologics should be explored in a broader population. What did you mean by that, or can you specify?
Yes, so thank you for your question. In my opinion, wider means also a bit quicker, because these agents are highly effective, as I mentioned, and are very beneficial, have very mild side effects. And according to current guidelines in our country, the patients should get in first line a conventional systemic therapy, which is not biologics. It's methotrexate, acitretinol, cyclosporine. And maybe if we could give, and we had this financial support to give a biological therapy in first line, maybe more patients could benefit from it. So that's why I'm understanding under wider patient populations.
I have a question related to your first study on cardiovascular risk. So in cardiology in general, if you have a patient population who is younger, it's really difficult to examine the cardiovascular risk and cardiovascular disease because you have to wait many, many years, even decades, to develop a major cardiovascular event. But in the literature and in the cardiovascular research, surrogate endpoints are also available, which are considered also good approximator of the real cardiovascular risk, right? For example, the pulse wave velocity and microvascular features can be used for this purpose. So did you consider running a study regarding those parameters?
Thank you very much for your questions. And actually, we conduct at the clinic this kind of research. So we are assessing cardiovascular risk with cardiac CTs and also with ultrasound as well. So these aren't meta-analysis at all. But well, for conducting a meta-analysis, this tracking these major adverse cardiovascular events looked the most accurate. However, when we talk about original research, we do these kind of researches in many, many ways. And also we are counting like ratios and everything. So we are very deep in this topic normally.